So what are the current pharmacologic options that are out there right now?
We have lots of different options. So the traditional ones is metformin. So after lifestyle modification, most guidelines are going to recommend metformin. It's a drug that's been around for a long time, generally well tolerated, and it's very inexpensive.
It's an oldie but a goodie.
It's an oldie and a goodie. Most people tolerate it very well.
See, he's even nodding and smiling.
Yeah.
Absolutely. Well, it's the first line. I mean, we expect that from everyone, but it's a good starting point. It's easy for the patient. In some cases, the co-insurance or copay maybe $5. So it's very affordable for patients as well.
So then we move on.
Then we move on, and then things become more complicated because we have lots and lots of choices, which is a good thing and a bad thing at the same time. From my perspective, it's a good thing because we have more resources, we have better drugs to offer to our patients. So it really will depend on what is the level of hemoglobin A1C, and that's one of the things that I really like very much about the ACE guidelines, because they stratified depending on the level of hemoglobin A1C. So if somebody presents with a hemoglobin A1C of less than 7.5, usually monotherapy will be appropriate for a short period of time, and the patient needs to be reevaluated. As said, we don't want to fall into inertia, which has happened so often, it still does happen. Then if somebody starts with a hemoglobin A1C between 7.5 to 9, it is very appropriate to initiate dual therapy. And what are the drugs? Well, it can be metformin, and it can be one of the other classes of drugs, GLP-1 receptor agonists, DPP-4 inhibitors, SGLT2s. We tend to stay away from sulfonylureas in general.
Why is that?
Well, there are a number of issues. Hypoglycemia is one of them. Weight gain is another issue. And we are already dealing with people that have a weight problem by and large.
Now, you mentioned some letters here, some word salad or alphabet salad. Mm-hmm. Those are letters that weren't even dreamt of in my philosophy back when. They're new.
Neither in mine. So we've seen the field exploding, and there are just so many new options, better classes of drugs that are really going to help, not just to treat diabetes, and to forestall the complications, but even to protect the pancreas to a certain extent. And we are talking about people with type 2 diabetes right now. Type 1 diabetes, you treat with insulin. There is no other.
Yeah, I was going to bring this up. I mean, you didn't really mention insulin until the end. And I know that when you mention insulin to patients, they often pull away. But isn't insulin a good drug? I mean, it's cheap.
Well, no longer. It's certainly not cheap anymore.
How about,
but it's
relatively
a great
cheap.
drug. It is a great drug, and that was going to be the next category in people that present with type 2 diabetes with a hemoglobin A1C greater than 9. It is appropriate to consider insulin as first-line therapy, particularly if people are having symptoms. If they're having symptoms, the first thing you want to do is to eliminate the glucotoxicity. That means all the symptoms associated with high blood glucose level.
Now, the patient reaction to insulin that I've seen is, oh my gosh, one, it's a shot, and two, my great aunt Agnes got put on diabetes and she died 2 years later. Yeah. How do you deal with that?
Well, I think, again, it's a matter of education. Education, as Dr. Jocelyn said, okay? Who, by the way, is 150 years old today if he lived. But anyway, I think we have a lot of choices, and we're very fortunate that we have some new, very good choices, particularly the 3 classes of drugs that we were just discussing, the DPP-4 inhibitors, the GLP-1 receptor analogs, and the SGLT2 inhibitors. Of course, patient will always prefer a pill, given the choice, rather than an injection, even though when we tell them how easy it is to take this injection in a little pen with a tiny, tiny needle, and they'll accept it, I think, if they need it.
Oh, yeah, but it's still a needle. Yeah. You know, we see needles every day.
The whole concept of needle is really ingrained.
And you have just presented a patient with a new diagnosis with a high sugar with a needle. Not only a needle, but they've got to do it themselves. You understand that, right? I mean, that's a little fearsome.
Right, it's the initial fear, and we worry about, I think 90% of the patients are seen in primary care physician's office. Okay, we don't have enough endocrinologists to see all these new patients of diabetes that are coming up all the time. So it comes down to resources. Do you have a nurse sitting next to you in the next office where she can show the patient how easy it is to take an injection if they have to? But again, I think even if they are given their choice, they will always prefer a pill over an injection.
Sure. You know what amazes me is the kids with type 1 usually. And they take their own shots. They monitor their own glucose.
Amazing.
They've got their own glucometers. And it's us grown-ups
Yeah.
that are a problem.
I know, and I see a lot of people that are afraid. I'll tell you what I do in my practice. I just give the first injection in the office. So I show the patients the pen. I show that 4-millimeter tiny, tiny needle, and they look at it, and I said, yep, now you're going to give yourself the first injection. And I actually guide their hands, so they give themselves the first injection in the office, and then invariably they look at me and they said, is that all there is to it? I said, yeah, I told you so. So it's easy.
Getting to the I told you so is the critical part.
Right.
Well, the technology is
Yeah.
so advanced now with insulins in terms of the insulin types as well as the devices. There are disposable pumps that folks can use that make it very easy. And I think we have a generation, an older generation, and you said it earlier when you said it's just a touch of sugar. There's this older generation that was threatened with the needle if they didn't toe the line
Right.
by the physician.
I was going to say that.
So you sort of got to get on beyond that with folks. I think the younger generation, that doesn't resonate. But for those older Medicare patients, if you go on insulin, that's the end is near, because that was the critical punishment or what you're going to have to face.
You
because
threatened them
didn't-
with the needle, huh?
Absolutely.
Yeah. Now, I saw your face. There was a little smile when she said insulin is no longer cheap. What's going on with insulin?
Well, there's no question the price of insulin has gone up dramatically. There's been a lot of excitement in Washington. There's been hearings to figure out why is insulin price increasing. We have had some insulin products launch recently that are less expensive. We don't have biosimilars necessarily for insulin, but we have follow-on protein products as they're defined. So there's different terminology, but they're similar. So they're biologics. They are less expensive. Lilly has launched a biologic similar to Lantus, the Lantus product, the Basaglar, and then we have the Sanofi just announced they're going to do a $99 insulin special for patients, so patients can actually sign up for a subscription program and get an insulin and pay cash for it at $99. But some of the insulins are $500, $600, $700 a month.
You'll forgive
For
me,
patients.
but insulin has been out there since the early part of the 20th century. This has been wrung out, and the patents should be long expired. So please tell me why it costs anything near that.
It's just the technology and the price increases from the companies over the years that have driven the price up. And as the new technology launches, it launches a new phase, if you will, of pricing, and it's a lot of competitive. There's a lot of rebating in the marketplace, which there's a lot of controversy about, which may drive up the cost of the insulins because the price goes up so that they can pay the rebates back. It's
But
really
you
kind of a
understand
vicious
why
circle.
this makes people crazy.
Absolutely.
This is insane.
I'm sure, Jim, you will really agree with me that I think it's been very complicated how the cost of insulin has been going up and up and up, and there's no generic insulin, 100 years after the discovery of insulin. And now, yeah, things are happening from what happened in the Congress a couple of weeks ago. Prices started coming down a little bit. We need to go a lot more.
So-
Because this is a life-saving drug. And think about people who ration their insulin. They don't take it.
Yeah.
half
It's
the
insulin
time.
or food.
They want to
Some
make it
people-
last
That's right.
longer.
Right.
It happens.
Oh,
It's a
absolutely.
huge
If you have
issue.
a patient with a coinsurance on an insulin, what if they have a 50% coinsurance, they have an exchange plan, they might be paying $300 or $400 a month just for insulin.